We are going live in 3, 2, 1. We are live now.
Oh. Good evening, ladies and gentlemen. Welcome to.
Just 3 minutes, just to join.
Sorry. I think we can start. We'll join.
Sure. Good evening, ladies and gentlemen. Welcome to Secrets of Neurology. It's a knowledge feast for all neurologists. This probably is one of the longest running web academic series in the field of neurology, maybe at a global scale. Today is episode 54th. And a very interesting title, A Game of Whodunit in Stroke, presented by Postgraduate Institute of Medical Education and Research, Chandigarh. A warm welcome to all the delegates, not just from India, but throughout the world. The two gentlemen on top, our course directors, is the brain behind this longest running neuro web series, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. We would also have the presence of faculty led by Professor Dr. Dheeraj Khurana and his academic partners, Dr. Sucharita, Dr. Parag, and Dr. Shipra. Warm welcome to all the delegates. We all know it starts on time and generally finishes on time in a period of 1 hour. A brief introduction. I know they have asked me to give a very brief. It is very difficult to define Professor Dr. Sudhir Shah in one slide. We know him very well, Professor and HOD at prestigious Srimati NHL MMC and SVPI MSR Ahmedabad. And Dr. Shah is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad, author of 6 books. On June 5th, 2024, he also received and was awarded as the French Senate Paltussi de Luxembourg, Paris, France, the highest international award for Indians. Dr. Sudhir Shah has also been conferred, because of his work into the field of academics, research, community, and patients at large, Padam Shri by Government of India in 2016. He is also recipient of PC Roy Award in the year 2018. Dr. Sudhir Shah's interest is into stroke, neurodegenerative disease, and epilepsy. We are also extremely grateful and thankful to our second course director, Professor Dr. Lakshmi Narasimhan Ranganathan sir. He made an institute, Madras Medical College, and today is leading as director and professor of Department of Neurology at prestigious Sri Ramchandra Institute of Higher Education and Research, Chennai. Many contributions in the field of neurology. Paltussi Advisor from AN, A.B. Baker's Award for Global Best Teacher, Best Paper Award by AN, Global Elsevier Atlas Award. But what he would be remembered the most is his contribution to young budding DM and DNB students across India. He has been a convener. He has been 3-term executive member of Indian Academy of Neurology. We are honored and we are grateful to both our program directors. May I request both of you to take it forward from here, sir.
Thank you.
Dr. Lakshmi, you want to start or may I?
Yes, sir, please, sir.
Okay. So, warm welcome to all of you, and it's our proud privilege to be with all of you again on this 54th episode of one of the most sought after web series for students and teachers alike. As Dr. Manoj said, this is one of the long-lasting, globally one of the longest-lasting web series for teaching. I think additionally, I must say it is one of the most consistent series. It is full of knowledge, so the quality of the uh, different episodes are also wonderful. All of them are archived, and it is a feast to see them again and again and learn. So you learn neurology stroke by stroke, or you learn neurology wave by wave. It is probably the same. And may I have the first slide, please? I must take this opportunity to first of all thank
Diksha, Shweta, load the slide.
all the different colleges, institutes, and teachers, professors, and students for giving their valuable cases and having spared their wonderful time for discussing all these cases, which was really a matter of great,
Yes.
you know, knowledge for all of us. So I received lots of notes from many professors, associates, and assistant professors also that they all enjoy the talks very well, and it is full of secrets of neurology, as a matter of fact. At the same time, students have been given platform to present their cases and dissect them, so that for them it's a way of learning and preparation for the upcoming exams. Today, I also must thank all of you, the delegates, for your consistent presence, because without your ex- participation and your encouragement, we would not have been able to continue this long. And we hope to continue this series as long as you pour interest in this webinar series. I must also thank heartily my co-course director, Dr. Lakshmi Narasimha, who is doing profound work to maintain the standards and selecting the cases also. And not the least, I would be thankful equally to Mr. Arun Chanda and his team of Celestial Division of Intas for their networking, for their infrastructure and support for this wonderful webinar series. Today, the institute is PGIMER, that is Postgraduate Institute of Medical Education Research from Chandigarh, one of the most premier institute of India. As you know, this is people look on to this institute for learning, and the case presenter would be Kshipra Nilkant, is a senior resident from the Department of Neurology. The case is, as I said, who done it? Who unit? Who who done it? So it's a very catchy name, and you can decide the way you like. So I'm sure you will enjoy. Shipra would present the case, and she's an MBBS from 2010 batch and MD Medicine 2020 from Armed Forces Medical College, Pune, and serving in Indian Navy since 2011. That is a matter of pride for all of us. Next, Dr. Parag Barwad Vaman Rao is an additional professor, Department of Cardiology, would be presenting the case localization and some kind of discussion from cardiology side. So I'm sure this must be a case of stroke, and there has to be something related to cardiology that we'll all come to know within some time. He's an MDDM with the fellowship in cardiology and FESC Fellow of European Society of Cardiology, FSCI Fellow of Society of Cardiovascular Angiography and Intervention. He has more than 100 publication articles and 558 citations. He is an associate editor, Indian Heart Journal, associate editor, Journal of PG Medical Education Research, and is a reviewer too. Indian Heart Journal, European Heart Journal, Indian Heart Journal, and Indian Pacing and Electrophysiology Journal. Next one, please. Dr. Sucharita Ray, a well-known professor from PGIMR. That is, she's an associate professor, Department of Neurology of Postgraduate Institute of Medical Education Research, Chandigarh. She has done her DM from AIMS, New Delhi, postdoctoral fellowship in stroke and cerebrovascular disorders in AIMS, New Delhi, and clinical fellowship in stroke and cerebrovascular disorder at Calgary, Canada. She is member of AN, IN, ISA, MDS, WSO, and CSC. There is 40 published articles and 14 book chapters to her credit. She's a reviewer in Stroke, Lancet, Annals of Medicine, International Journal of Surgery, International Journal of Surgery, AIN, and Neuroophthalmology, etc. Her special areas of interest are stroke and cerebrovascular disorders, headache, dementia, clinical research, and evidence-based medicine. Next slide, please. So Sucharita is a well-known professor from Chandigarh, and none less than Dr. Dheeraj Khurana, our friend, professor from the same institute, is likely to add final remarks after Sucharita gives comments on summary and conclusion. Dheeraj would add to it, and as you all know, he is also a prominent figure from PGI. He is a professor in charge stroke program. He has more than 150 publications. He's an awards winner like 2020 International Stroke Conference Stroke Rehabilitation Award, Paul Dudley White Award of the American Paul Dudley White Award of the American Heart Association of the highest rated abstract of the International Stroke Conference 2020, 2020 QI Innovation Award of the AAN Practicing Physician Quality Award 2014, finalist for the BMJ Awards India 2014, National Coordinator of the SITS Sales Registry of Stroke, National PI for the Multicenter Trial Mobility Instruct Network, is a board of editor of the European Journal of Neurology, European Stroke Journal, associate editor of JEPMAR and Journal of Stroke Medicine and IJNCD, past editor of Indian edition, European Journal of Neurology. As we all know, his interest mainly in stroke, and he established the PGI stroke unit, and also is interested in health and neuro rehabilitation aspects of stroke. He is a fellow of Indian Academy of Neurology, chair Telehealth subsection of Indian Academy of Neurology, vice president of World NCD Federation, past president of Indian Stroke Association. On a personal note, he's a very good singer, vocalist and guitarist, and we all relish his songs during our Nuregama meetings during different conferences. So I welcome you all on behalf of me and my colleague, Dr. Lakshmi Narasimhan. Thank you very much. And with that, I hand over to Sucharita ji to start the proceedings. Thank you very much.
Thank you, sir. Thank you, Lakshmi sir, for giving us this opportunity to present this slightly different case. And thank you, the organizers, Arun Chadha ji, Dr. Manoj, and Diksha and Shweta. So today we were told to present a unique case that will give insights to the residents to actually learn a new aspect in neurology. And this has been going on. Even I have been part of the learning team at one point of time for all the excellent cases that are always presented. So today we found out this opportunity and tried to present a complex case, which we actually see in our clinical experience, but people don't have too many answers to. So this is usually the clinical scenario that you feel. And since we are interested in stroke, as Sir said, so we will be presenting this case, so who has multiple strokes and slightly different. So for all residents, it is known that localization is relatively easy in stroke, but management is difficult. And I think Dr. Shipra will, as she will present, you will realize how common and how familiar such situations arise. And what usually happens is we are at a loss how to manage them in clinical practice. So over to Dr. Shipra to present the case. And she will be localizing and giving the basic course, after which I shall be talking about some of the therapeutic aspects. And Dr. Parag has joined us from his schedule. He's probably attending a conference in Delhi, but was kind enough to accept. So he did some procedures in the patient, which he shall be talking about, and he will illustrate his decision for this management with some other videos of some other patients also. So over to you, Dr. Shipra.
Thank you, ma'am. Are my slides visible?
Yes, ma'am.
Good evening, everyone, respected sirs, ma'ams, and dear colleagues. Today, I would present a case of an interesting case of stroke, a game of whodunit in stroke. So my patient, Mr. X, 64-year-old gentleman, graduate and a retired forest official, hailing from Hamirpur, Himachal Pradesh, right-handed individual, in common being self and his son with good reliability, presented to us with recurrent neurological deficits. He had 2 episodes. First episode was on the 13th of March 2024, and the second episode was on the 19th of October 24. On 13th March 2024 at 1900 hours, when patient was entering his house, he had a sensation of acute onset giddiness in the form of revolving of self. This was associated with an imbalance such that he could not bear weight on his right lower limb and had to sit down. He was further helped by a bystander into the house, where he was able to lift his right arm and take support of the bystander. He was also able to walk into the house with one person's support. Simultaneously, he also noticed that he was having difficulty in speaking, such that he was having slurred, incomprehensible, and effortful speech. These deficits were maximal at onset. There was no history of headache, tinnitus, vomiting, sweating, chest pain, or palpitation. There was history of significant stressor at home. That is, one of his relatives was admitted in the hospital, for which the patient kept visiting hospital in the past 2-3 days before having the stroke. While visiting in the hospital, he had feeling of exertional dyspnea and palpitation. And on one occasion, there was a recording of blood pressure of 150 by 90 mm of Hg in the emergency room of the hospital. He was started on antihypertensive from the hospital. However, patient did not take the same. He is married with 2 kids, consumes vegetarian diet, a non-smoker, does not consume alcohol, and has no other addictions. He is a known case of hypertension since 3 years. However, he's been on alternative medication. So with these complaints, he was taken to a local private hospital, which the records showed that he was conscious and cooperative, had a heart rate of 90 per minute. A high blood pressure was recorded in the form of 220 by 150 mm of Hg, and there was right-sided weakness and aphasia. He was given injection Lasix 20 mg stat. He underwent neuroimaging in the form of NCCT head. This here shows the NCCT head, which was taken 3 hours into the onset. Here we can see the first thing which is predominantly seen are the periventricular white matter changes, which are basically the leukoariosis, which is the pathological appearance of the brain white matter, which are caused by the perfusion disturbances within the arterioles perforating through the deep brain structures. The CT appearances of the leukoariosis is graded by the Van Wheaton score. The Van Wheaton score was given in 1990 by J.C. Van Swieten and A. Hijra, where they graded these changes in grade 0, 1, and 2. Grade 0, where these changes were absent. Grade 1, where they were partly involving into the white matter. And grade 2, where they were extending up to the subcortical region. The white matter changes anteriorly and posteriorly were further seen. Anteriorly at the level of choroid plexus and the sella media, and posteriorly at the level of sella media and the centrum semiovale. So as seen in this CT, in case of our patient, he had anterior white matter changes of A1 grade, whereas in case of posterior white matter changes at the level of centrum semiovale, he had the white matter changes extending up to the subcortical region. So he had the Van Swieten scoring of our patient was A1, P2. In addition to that, the CT also showed a left occipital hypodensity, likely an old chronic infarct. Further chronic lacunar infarcts were seen in the right centrum semiovale region, and a probably evolving hypodensity in the form of an hyperacute infarct was seen in the left frontoparietal region, in the form that the gray-white matter interface was lost at this region. The patient presented to PGI Chandigarh at 0120 hours, that is 6 hours 20 minutes after the onset of the symptom. On presentation at our center, clinically his NIHS was 18. He was confused. He had a heart rate of 106 per minute, which was irregularly irregular, a blood pressure of 156 by 90 mm of Hg. Neurologically, he had right 7th UMN palsy, Broca's aphasia. On motor examination, his power in the right upper limb was 0/5 and lower limb was 1/5. The plantar was extensor on the right side. At presentation in our emergency, he underwent an NCCT head and CT angiography. Here we can see this is the CT of the CT head of the patient, which is 6 hours 20 minutes into the onset of the symptoms. Here the hypodensity, which we were likely seeing in the previous CT, has become more clear in the form in the left frontoparietal region. In addition to that, we can see that there is a central hyperdense lesion, which probably is the hemorrhagic transformation to this infarct. He also underwent CT angiography at presentation. This is the CT angiography coronal view, which shows that the ICA on both sides, the intracranial part of the ICA on both sides is well formed. At the same time, it bifurcates into the ACA and MCA, and it is well formed over here. The sagittal view shows that the MCA divides into the superior and the inferior division, which is well shown till about the M4 part of the inferior division of the MCA. Here, the extracranial part of the ICA can be well visualized and well formed. There are few atherosclerotic likely changes which are seen. However, the ICA is well formed. The ECA is well formed. He underwent basic evaluation in the form of routine evaluation, which showed normal platelet and INR levels. An ECG revealed atrial fibrillation with fast ventricular rate. Cardiac evaluation showed a 2D echo with a normal LV ejection fraction, trivial MR, and LA size at this point was 2.2 centimeters square. There was no apparent clot or vegetation. 2 days into the illness, we can see that the infarct has become more well formed in the form in the left frontoparietal region. It is surrounded by the cytotoxic edema. At the same time, a hyperdense lesion, which was the hemorrhagic transformation which we had suspected in the first place, can be well seen in this CT. These lesions were hypodense on T1 weighted imaging in the MRI brain, hyperdense on T2, and on FLAIR imaging, which were diffusion restricted, and on SWI showed scattered blooming, suggesting a hemorrhagic transformation. At the same time, in the FLAIR, we can also see periventricular white matter changes, which are non-diffusion restricting, most likely chronic microangiopathic changes. So final impression that was made was this 64-year-old male, a known case of hypertension, not on medication, presented with right hemiparesis, right UMN facial nerve palsy, and aphasia, imaging showing left MCA territory infarct of 6.5 hours duration with likely hemorrhagic transformation. CT angio had shown a normal anterior circulation with a right vertebral artery occlusion and atrial fibrillation. In addition to this, features suggestive of chronic microangiopathic changes were seen in periventricular region, extending up to bilateral centrum semiovale. So he was diagnosed as a case of cardioembolic stroke. He was observed in emergency for rate control and blood pressure was optimized. Subsequent clinical course that he improved in the sense that he had started standing with support in the hospital itself. He underwent a CHA2DS2-VASc score in the calculation in our patient, which revealed that his score was 3, 1 for hypertension and 2 for a stroke that had developed, depending on which he was started on anticoagulation, tablet warfarin 5 mg OD, in addition to the medication as shown up. He started improving at home such that he required one person's support to walk, but continued to be aphasic. His right lower limb power improved over next 6 to 7 days such that he was able to walk with one person's support. And further, over the next 1 month, he was able to walk without support. His right upper limb power improved in the form. In the next 3 to 4 months, he has started moving his fingers and arm up to a shoulder level. However, he required assistance for his activities of daily living. On further follow-up, patient then presented to neurology OPD on 29th April, that is almost 1.5 months after the first onset of the stroke, with history of 1 episode of bleeding from oral mucosa and ecchymotic patches which were developed over his right thigh. He underwent urgent INR, which was 3.18, and his drugs were optimized to ensure the correction of the INR. Urgent evaluation also revealed an HbA1c of 7.5% and a BNP of 1,318, which was increased. A repeat 2D echo this time showed that his atrial fibrillation was there with fast ventricular rate, and the left atria was dilated 4.6 centimeter. In addition, he had concentric LVH. Ejection fraction was 55%. The etiology of atrial fibrillation was the appearance of the LA, which was chicken wing appearance. His medications were optimized, warfarin was stopped, and he was started on tablet apixaban 5 mg BD, which was further increased to 7.5 mg BD. For the definitive management of atrial fibrillation, he was evaluated by a cardiologist and diagnosed as a case of persistent AF. He was dated for AF ablation on the 15th of July 24. However, owing to his clinical improvement, he did not seek further care at PGI, but however continued to have good drug compliance. He gradually improved such that he started mobilizing without support. He, however, remained aphasic. The event 2 now occurred on 17th of October 2024. It was apparently okay till 17th October 2024, till 1900 hours, when while resting, he developed sudden onset right hemiparesis associated with giddiness and reduced responsiveness. There was history of right facial droop. This was also associated with 2 to 3 episodes of vomiting. He was managed at a nearby tertiary care center, which was 2 hours away. There was no history of headache, tinnitus, sweating, chest pain, or palpitation. On presentation at this tertiary care hospital, revealed that he was confused. He had irregular heart rate of 90 per minute. BP was 132/82. And he had a right UMN 7 nerve palsy and right hemiparesis. The power at this point of time was the upper limb was 3/5, and in the lower limb, the power was 4/5. He underwent an urgent NCCT head again at this tertiary care center, the terms of which are not available with us, which showed an ill-defined hyperdensity measuring 5.2 into 3.6 into 4.9 centimeter with a volume of 50 to 60 cc's involving the left gangliocapsular region with surrounding edema, and it was causing there was no midline shift. The CT also revealed a right frontal lobe, likely a lacunar infarct, and a left frontal frontoparietal and left occipital chronic infarcts. The investigations were essentially normal. The management and clinical course in the tertiary care center was that they had discontinued apixaban. He was given anti-edema measures in the form of mannitol. He was also exhibited injection dexamethasone, which was tapered over the next 3 to 4 days. Anti-epileptics injection levetiracetam was added. He was also exhibited with vitamin K 10 mg and prothrombin complex in view of the hemorrhage. In hospital course, he had developed UTI while being admitted and was managed with culture-sensitive antibiotics. Patient was discharged on 3rd of November, that is 2 weeks after the onset of the second stroke. He was planned for restarting anticoagulation on follow-up. Post-discharge, patient presented to PGI Chandigarh, and an impression after seeing this was made of either an apixaban-induced ICH or in the background of hypertensive ICH. He underwent MRI brain imaging, which showed the persistence of left frontograndiolocapsular capsular region and insular cortex ICH, which was T1, T2 hyperintense, and it was suggestive of a late subacute bleed. Here we can see that this the imaging done at this point was hyperintense on T1, hyperintense on T2, and it was hyperintense on flare. In addition, in flare, we can also see periventricular white matter changes. The GRE shows the hypointense. So most likely it was a late subacute bleed. He was diagnosed as a case of anticoagulant-induced bleed, likely due to chronic, the chances being more likely due to chronic microangiopathic changes that were already there in this patient, making him susceptible to the bleed, or he could have been anticoagulant intolerant. Multi-specialty discussions were carried out and he was planned for LA occlusion. He underwent left atrial appendage occlusion on 30th November 2024 with Emplaza Amulet 25 mm device. He was admitted 3 days at our center for the same procedure. Post-procedure, the post-procedure was uneventful. So in our case, the unique discussion points were that when we see a stroke case, we have to formulate an etiological diagnosis of the stroke. And this can be done by using NCCT head as one of the main modalities at emergency to differentiate between embolic and thrombotic stroke. Whether warfarin or DOAC should have been used for secondary prevention in patients with AF, and the time for the initiation of the anticoagulation in the cardioembolic stroke. Risk stratification of the patients with cardioembolic stroke and the atrial fibrillation and management of such high-risk patients of cardioembolic stroke with AF. So stroke or cerebrovascular accident is defined as brain, spinal cord, or retinal cell death attributable to ischemia based on neuropathological, neuroimaging, and/or clinical evidence of permanent injury. They are mainly categorized into ischemic stroke or hemorrhagic stroke. In short, we'll just see the approach to etiology of stroke. When we see a patient with ischemic stroke, according to the TOAST classification, the etiological classification, we need to classify whether it's a large vessel occlusion, which is causing the ischemia, which can be either the ICA or the intracranial occlusion. This occlusion can be thrombotic or embolic. The points in favor of thrombotic show that it can be a well-defined area of hypodensity, which is restricted to a vascular territory. This may be associated with cytotoxic edema, and generally patients with thrombotic stroke have a gradual progression. There can be a visualization of a clot or a dense MCA sign, which is commonly seen. Whereas in embolic stroke, they are seen as multiple scattered area of decreased signal intensity, which are seen in various territories. They are generally wedge-shaped in appearance, and they are seen over the watershed areas. The clinical symptoms are generally rapid and acute, and the chances of hemorrhagic transformation for this infarct is higher in case of an embolic stroke. Clot may not be seen because the clot is friable and may be lysed. In addition to that, small lacunar infarcts are formed because of the small vessel occlusions, generally because of the perforating branches. Cardioembolic stroke, commonly seen with atrial fibrillation, leads to an embolic phenomenon of large vessel occlusion. Other determined etiology can be either cervical artery dissection or prothrombotic stage, such as an APLA or a tumor related, or genetic and carousel. Whereas undetermined etiology can be 2 or more causes with negative evaluation, or in which case the patient has not been completely evaluated. So with this, I would like to summarize that when we see patients in emergency, our first approach should be to find out the etiology of the stroke and thereby work the patient accordingly. Thank you.
Thank you, Diksha, for presenting this difficult case. I would like to present my slides, so just loading them. Could you kindly unshare? Are my slides visible? Am I audible?
Yes, ma'am.
So this case basically underwent left atrial appendage occlusion and presented with multiple strokes. So there are many doubts which I'm sure that the audience would be having, but this is exactly the kind of cases that we see in emergency. So there are some of these query points that fill us with doubt, and so we will be tackling them. So first of all, the patient presented to us with a second stroke. The first one was diagnosed outside, and he presented with deep hemiparesis to the right with aphasia, and NIHSS was 18 when he came here. He was well into 7 hours at the time of presentation. So obviously the suspicion, as Dr. Shipra pointed out, is that of a left MCA stroke. So as you could see in the scans that she presented, there were evidences of very subtle acute infarct happening in the left MCA, but there was a significant development of a hemorrhagic transformation there. At the same time, as she showed, the anterior circulation was fully patent, thereby meaning that there was no acute clot that we were worried about. This was probably what was going on in the minds of the emergency team because there was no acute occlusion, and hence the decision was taken to just manage this patient conservatively, because when you see such patients with hemorrhagic transformation without an acute occlusion and you see an atrial fibrillation, you definitely think that there is probably a big hemorrhagic risk that will be present, and most likely the clot that was present in the MCA has kind of lysed. At the same time, like Dr. Shipra showed, she had grade 3 microangiopathic changes. So these patients are also kind of high risk for a bleeding tendency, although that should not keep us from thrombolizing when they arrive to us in the emergency. There was at the same time a left vertebral occlusion with a left-sided occipital infarct. So that was probably their chronic infarct that had formed, which probably the patient had overlooked, or we were not able to access those medical records. So in any case, the patient was admitted and managed conservatively. And as atrial fibrillation was found out with high ventricular response, the initial plan was to control the rate and rhythm and then to also start anticoagulation. Now, anticoagulation initially was discussed in the emergency. So sometimes while you do it, you are in a hurry to discharge the patient. And one of the obvious choices, sometimes looking into it financially and everything, is warfarin. And warfarin and acetrom are great anticoagulants to this point in time. We have them as being very efficacious in patients who have atrial fibrillation for secondary prevention. So efficacy-wise, they are great choices, but they develop side effects. So in this particular patient, warfarin was decided as an anticoagulation, and he was sent with further management and follow-up in the OPD. Over a few weeks, he improved, as Dr. Shipra showed, but then with therapeutic INR, so 3.1, he developed mucosal bleeds and petechia. So clearly, he was not tolerating warfarin. And when they came to us in the OPD for a follow-up, he actually said that he had multiple episodes of epistaxis as well, with some ecchymotic patches that would form on and off, and he was very desperate to change the drug. And obviously, when we now have enough evidence for comparison of direct-acting oral anticoagulants, and when you have a patient like him who has a non-valvular atrial fibrillation, the treatment of choice now clearly veers towards giving direct-acting oral anticoagulants. And so we have options of dabigatran, rivaroxaban, apixaban, and now newly introduced edoxaban is also on the way. So all of these drugs are great, but there are some risk-benefit profiles. And out of all of these drugs, if you have an elderly patient who presents to you with a non-valvular AFib and has a potential cardiac side effect, edoxaban would be the best drug that you would prefer because it has got the least complication rate as compared to dabigatran and rivaroxaban. Second, it does not require it does not require food modification. It's not renally excreted to the extent that dabigatran is. And if edoxaban is not available, like in our setup, and now we have generic drugs, apixaban is the next choice. And so apixaban therapeutic 5 milligrams twice daily, and that is what he was kept on. But the patient continued to have fast ventricular response with atrial fibrillation, which is why the initial echo and we had suspicion that there is some ongoing cardiac problems, which is why we repeated the echo and we also tried to find out some markers as to whether he was having any other side complications or any ongoing cardiac issues that was happening. If you saw what Shipra was presenting was that, the initial echo showed a left atrial size, which was quite normal. But when we repeated the echo and the pro-BNP, which are markers of cardiac function, the left atrial size had considerably enlarged. The patient continued to have AFib with fast ventricular rate. The ejection fraction kept on being preserved. And so these were signs of an impending left atrial cardiopathy with suspicion for resistant atrial fibrillation. And this person had had 2 strokes with us. And so now he was on apixaban. Apixaban dose was hiked from the cardiology side due to the high risk profile, and he was actually evaluated in cardiology and counseled to undergo atrial ablation, which is an ablative procedure where in these difficult to treat cases, you actually try to ablate them to achieve rate and rhythm control. But like you have in practical settings, patient goes home with reassurance to follow up in OPD. So he follows up, he does not follow up in OPD because he tends to get better. And so he continued to be on oral anticoagulants, but he never followed up. And so the third episode was actually a bleed. And this again, they did not have time to come to PGI, so they were admitted in a nearby tertiary care center. And he presented with a large bleed, so large as to it was actually life-threatening. And at the admission, he had a 60 cc capsuloganglionic bleed with evidence of normal blood pressure. So 132/60. So not exactly a hypertensive bleed, but somewhere a bleed that has become so large that it has actually occupied the entire space. So obviously with normal blood pressures, and when he presented within a few hours, he was treated with what we know as PCC, prothrombin complex concentrate, otherwise called Octaplex. So when you have patients who are on DOACs, they present to you and they come with a bleed. It's always a good idea to give Octaplex if they come within 24 hours. And if it's a rapidly expanding, threatening bleed. So while he was waiting to be transferred, they gave him Octaplex and managed him conservatively. And then subsequently, he was referred again to us. After a couple of weeks, actually, when he had kind of come out of the danger zone, ideally a neurosurgical consult would have been a good idea to consider during that time. But they did a tremendous job there by managing him supportively, giving him Octaplex in the first instance is a great idea to prevent further hematoma expansion. And after great amount of conservative management, BP control, discontinuation of oral anticoagulants, he came to us. So clearly, when you have such patients with us, you are having an acute stroke with atrial fibrillation in the first instance, and then you have a patient who has been put on therapeutic anticoagulation, planned for some cardiac measures, and then the patient is again developing a bleed. So first with warfarin and now with apixaban, this patient is not tolerating oral anticoagulants that well. And with a CHA2DS2-VASc of that is, more than 3, 4. So we have to, and now with the onset of suspicion of probable some cardiac failure status happening, it could even be more. So risk stratification wise, the patient falls into high risk category for a patient who has recurrent strokes with atrial fibrillation. And so the entire premise of the patient is developing multiple strokes of different types, ischemic strokes and then bleeds, with evidence of chronic lacunar infarcts, which are probably due to hypertension, which he's having. And so with the patient who has multiple episodes of difficulty getting managed with any type of oral anticoagulants. And so that is the premise in which a multidisciplinary meeting was taken, and there was a suspicion that we need to treat his LA cardiopathy. Although when he came to us, he was not having, when a third echo was done, he continued to have evidence of LA cardiopathy with a left atrial appendage that was a high risk of appendage called chicken wing, which I shall be talking about later. And so the plan was to actually occlude that area in order to prevent further ischemic strokes from happening and hopefully to control the atrial fibrillation. So basically, the choice for oral anticoagulants has come to us from multiple medical trials. We have the RELY trial, the Aristotle trial, and then later on for edoxaban, all the drugs that I mentioned, we have ENGAGE-AF and ROCKET-AF. But if you look at these patients, you actually see that when they're put on these, therapeutic measures, and when you look at the CHA2DS2-VASc, you see that they are relatively low CHA2DS2-VASc patients. So good CHA2DS2-VASc in the sense that maybe younger patients who may or may not have hypertension with AFib, no evidence of cardiac failure, probably no strokes or TIAs. So great patients with probably smaller strokes present to you, and they have been followed up for only a couple of years. But in clinical practice, we would need to follow them up for their lifetime. And so in these patients, all these direct acting oral anticoagulants did very well in comparison to the standard of care that was warfarin at those times. And as you can see, apixaban, edoxaban actually performed very well in comparison to all the others, and dabigatran was also very effective. But a 150 milligram dabigatran had a lot of side effects of bleed as compared to the standard therapeutic 110 milligram twice daily. So the disadvantage was that we really have to think and be very careful when we treat high-risk patients with recurrent strokes due to atrial fibrillation. And so this is a very busy chart, but the basic flow chart when you have a patient who comes to you with complicated strokes in the setting of atrial fibrillation is that first of all, you see if it's a stroke, and then you see if the patient is developing an ischemic stroke or a hemorrhagic stroke. Our patient had both, but at different points of time. And then once when you have acute ischemic stroke, you need to find out whether the patient is a known patient with atrial fibrillation or if you are diagnosing atrial fibrillation at onset. So for us, the patient actually ended up having atrial fibrillation diagnosed in emergency at his second stroke. Then once you diagnose atrial fibrillation, half your job is done, because now you know that you either have to start a DOAC or a warfarin. So depending upon what you want to do, you first always give a trial of oral anticoagulants and look at how well the patient is tolerating. And at the same time, it is always crucial to do a risk stratification of the patient and giving him multiple options. You have to tell him that these are the side effects of warfarin. This is the way in which you shall maintain therapeutic INR. These are your drug considerations that you will have. And also that you will be requiring regular monitoring of warfarin for INR. DOACs do take care of the routine monitoring part. Many of them, apart from rivaroxaban, don't need a lot of food guidance. Only rivaroxaban you require to give after food, but most of the others you can do away. But still, even after you give DOACs, you have to be very careful because you need to follow them up both for atrial fibrillation, for rate and rhythm control, development of any future complications, and tolerance to DOACs. On the other hand, if your patient comes with an ICH with an atrial fibrillation, which you either diagnose or which the patient already has, then obviously initially you need to take the patient off the DOAC. But you also have to first consider that if the patient has remained on direct-acting oral anticoagulants or warfarin, you have to first of all consider this as a DOAC complication or a system failure, and then you immediately tackle it. So in the acute period, you try to bring down the INR. In the case the patient is having warfarin, you give a PCC, very low volume. It's easy to take, it's slightly costly, but well tolerated by patients, does not precipitate heart failure. Many of these patients have a compromised cardiac function. And then subsequently, once the patient's initial aspect has been taken care of, the ICH is out of danger, then you try to detect all the high-risk features for the patient to develop an ICH, and then probably consider these therapeutic options. So what is the left atrial appendage that we are all talking about? It's basically a very complicated structure that is present in the left atrium. Its function is to maybe counter the effective, the blood flow and maybe act as an extra reservoir. It is known to secrete some cardiac specific hormones. And so this is an appendage which is probably not useless as we think. We still do not know much about it. And so apart from all of that, it's important to know that you always look for the contractility of the left atrium, and Dr. Parag is there to give you details on that. And these contractions disappear when atrial fibrillation develops. And so it's very important to actually find out this left atrial appendage, because it is thought to be a chicken and egg problem. So sometimes it is thought that left atrial appendage gives rise to chronic atrial fibrillation, or maybe chronic atrial fibrillation causes stasis of blood in the left atrial appendage, causing thrombi occurring in the left atrial thrombi. And so almost 90% of thrombus which are in the left atrium probably originate from the left atrial appendage. And these are the sources of ischemic strokes, cardioembolic strokes happening during atrial fibrillation. And so when we talk about risk of ischemic strokes in patients on anticoagulation, despite what we think that apixaban and warfarin is doing great, when you compare oral anticoagulation, even if you change it or you don't change it, you have an annual risk rate of almost 8 to 10%, depending upon the type of oral anticoagulation used. You also have a 1 to 3% annualized risk rate of ICH, and mortality is very high, topping more than 10%. So it is not without its dangers once the patient has had a stroke and is on an anticoagulant, even if you change the anticoagulant. So again, Parag sir will talk in details about this. We have multiple types, out of which chicken wing appearance is the most common. And so the shape determines the length of the clot that may be formed, and also the atrial fibrillation. All of these things can give rise to a chronic atrial fibrillation that is difficult to control, and additionally cause thrombi during ischemic strokes, causing recurrent thrombus and a resistant clot that can be very difficult to handle. So how does this thrombus happen? Mostly because of the stasis of blood that occurs during atrial fibrillation. And so we have to be very careful for this clot functioning. And over a period of time, this left atrial appendage actually undergoes remodeling, causing reduced contractility of the entire heart, and it progresses to cause cardiopathy. So there have been some trials that were used for finding out and tackling these patients. And so one of the earliest trials that was done was way back in 2014, where left atrial appendage closure was planned with device, and it was compared against warfarin. And so it was seen that for the composite endpoint, whether it was a stroke or an unexplained death or a systemic embolism, left atrial appendage closure did very well as compared to warfarin. And so basically, in this particular trial itself, the closure met criteria for non-inferiority as well as superiority, thereby giving us hope that in these resistant cases, we may try left atrial appendage closure. And similar results were also reflected in your other studies. Now, later on, when you have this appendage occlusion, this was also done in patients who have undergone cardiac surgery, and they have also shown to have great benefit. So overall, when you find a flow chart, a patient with atrial fibrillation, you basically have to know to find out whether the patient is on mechanical heart valve or it's a non-valvular AFib. If it's a mechanical heart valve, the treatment is clear, it has to be warfarin. And once it is always to be monitored for the CHA2DS2-VASc risk stratification. And once the patient also has a non-valvular AFib, you can decide whether the patient is a better candidate for DOAC if they can afford it. And now we have generic drugs. You prefer DOACs or NOACs over the traditional anticoagulants. But once the patients recur for strokes or the atrial fibrillation is difficult to control, you try these other measures that we shall speak about. And so the potential indications right now for these patients who have recurrent strokes with atrial fibrillation is for a failed oral anticoagulant. When you have recurrent ischemic stroke in patients using oral anticoagulant, our patient did not have that. Severe bleeding occurred during oral anticoagulant. So definitely our patient falls into this category as an alternative to patients with oral anticoagulation with high bleeding risk, and on top of oral anticoagulation to further decrease the risk of stroke recurrence. So overall, I will just show the last panel. So this is when we should think about all these other non-pharmacological measures like an appendage occlusion and over in addition to the DOAC, in order to control the risk of stroke and also to prevent further clots. And especially if the patient is resistant to oral anticoagulants, we have to think this as a therapeutic option. So overall, for recurrent strokes, it is of significance in patients mostly with recurrent with cryptogenic stroke. You look for left atrial enlargement because this can be both the cause and effect. And so when you have difficult to control disease, there is at present an equipoise for the management of strokes with cardiopathy, but Dr. Parag has answers to these patients, and these conditions are rare. But then you also talk about atrial fibrillation, left atrium size, presence of a clot, and take a decision with multi-departmental discussion to try and to find a potential solution to these cases. And this is just a meta-analysis that showed that the left atrial occlusion was equally effective to that of oral anticoagulation for a long-term management. Whereas now for these cryptogenic strokes, where an LA cardiopathy could be suspected, maybe we do not have a clear answer, but then probably cardiopathy and its management is an evolving field, and cardiologists have to manage that aspect in conjunction with the neurologists. Thank you so much for your hearing. I will request Dr. Parag to kindly clear the concepts here and show us his illustrative cases.
Thank you, ma'am. Thank you very much. Am I audible nicely? Because
Yes,
I'm presently doing two things at one point of time. Is like I have my laptop, which I'm able to show probably my cases, and I'm talking through my phone because of the lack of because of the poor connectivity here, I'm not able to actually talk through my laptop.
You are audible, sir. No problem.
Yeah, if I'm audible, I'll just go back in terms of, okay. So thank you, Sucharita, and thank you for all the organizing teams for actually calling me a cardiologist, like out of the context of neurology. But definitely everybody knows that cardiology and neurology is interrelated, it's part of medicine. So I'll be talking about left atrial appendage occlusion. I'll be showing what we did in this case, especially for his recurrent stroke and then anticoagulation induced bleed also. But again, a food for thought, whether atrial cardiomyopathy exists and causes stroke. So very important thing. Everybody knows about atrial fibrillation, that atria is contracting at a very chaotic rate and rhythm, maybe 300 to 450 per minute, and then ventricle is contracting at a particular rate. But atria will develop some sort of scarring, and then there will be chances of clot formation within the atria, which can embolize. So we all know that 30% of all strokes are actually cryptogenic stroke, where you try to find out all the causes and you actually are not able to find any cause to it, and they are called as embolic stroke of undetermined sources also, because there are multiple territories involved. But there is a concept called as atrial cardiomyopathy, wherein the atria slowly, the myocardium of the atria gets scarring. It gets scarring because of various causes. It may be primarily AF causing the atrial scarring, or it is the atrial scarring which may also cause AF. So it's again a chicken and egg type of phenomena, that whether the atrial cardiomyopathy came first or the atrial fibrillation came first, nobody is sure about it, and even we also don't have an answer to it. But more importantly, what we need to do is, if we are able to know that patient is having atrial cardiomyopathy, usually the treatment of stroke is you try to give antiplatelets to these patients. But if there is an atrial cardiomyopathy and you still don't have a documented atrial fibrillation, it is better to give anticoagulation to these patients. These things have already been told to us by Sucharita as well as by the senior resident who presented the case. So I would like to say that what I would like to say that why and when we would like to diagnose a case of atrial cardiomyopathy is when we have these type of things. This is cardiological perspective, may not be that relevant to the neurologist, but this is what we see when the patient comes to us and we diagnose atrial cardiomyopathy in the absence of atrial fibrillation. There happens to be a prolongation of PR interval, abnormal P waves. Patient can present with supraventricular tachycardia. Left atrium starts enlarging. Usual criteria is like 4 centimeters, means like the left atrium is enlarged, and it further enlarges, and then the chances of clot formation happens in this case. So again, a chicken and egg type of feeling, whether AF comes first, causes atrial cardiomyopathy, or the atrial cardiomyopathy causes atrial fibrillation, we really don't know. Coming to now our case. So as Sucharita has told about the different morphologies of left atrial appendage, this is our case. So what we do in a left atrial appendage closure is like when we take the patient on table, we give him general anesthesia, we put in a transesophageal echo probe. You can see that I'm now taking my marker to this black rod, which is a transesophageal echo that the patient esophagus, we put in a probe and we see the heart from behind because we need to do a transseptal puncture. What do you mean by transseptal puncture is we actually puncture, I don't know. Is my slides moving?
Yes, sir.
Yeah.
The video was visible. I think you can.
Videos are visible. Okay. Oh,
I think you.
screen sharing has stopped. I don't know why.
I think you can share again.
Yeah, I'll share it again. I'll share it again. This is the problem of this place. This place doesn't have a good internet connectivity. Is it now visible?
Yes, sir, we can see.
Okay. So this is the outpouching of the left atria. Our pigtail catheter is there, and we see the morphology of the left atrial appendage is the chicken wing type of variety. And what we do then is we go from the right atria, puncture the intraatrial septum, go into the left atria, we make a hole in the heart, which was not there. Then we take a sheath. This is a 14 French sheath, which goes in. And initially, we try to plug this left atrial appendage with a plug. And then there is a disc also, which covers the ostium of the left atrial appendage. But the first device was a bit larger in size, so we had to use a second device. And the second device, oh, sorry again, there's a problem with the connectivity. I'm really sorry for this. I apologize because if I would have been in my own place, I would have actually done it through my house, but I'm then somewhere outside. So we have taken a bit smaller device, and then the disc was deployed, and we completely occluded the.
We can't see your video, sir.
Oh, now I'm actually sharing my videos. So my videos are not visible?
No. We can just see the folder desktop.
Oh. Is it now visible?
Yeah, we can see your slides, sir.
Okay. Are they full screen? Yes. Okay.
Yes.
No, so
Maybe we could go ahead with the presentation, sir, if it's not loading.
no, I don't know, but it's not coming up the way it should come actually. So let's forget that about I'm sorry for that. So what we do is basically we try to occlude the left atrial appendage completely and try to make that part exclude from the left atrium. So because all that presentation doesn't appears to be now there on my it's crashing. Actually, the system is crashing. I've tried it 3-4 times. The system is crashing. Okay. So rather than me presenting on the laptop, I will actually talk through my phone, and I would be saying I'll be telling that what we do is we try to actually exclude the left atrial appendage from the left atria, and over a period of next 3 to 6 months there happens an endothelization of the whole disc, which causes that left atrial appendage completely out of the out of the heart, means that that is actually excluded from the system. So what benefits does it give to you is that there doesn't happen a clot formation in this. As Sucharita has already said, that 92% of all the clots form in the left atrial appendage. So you're taken care of the 92% of all the clots which will form in the left atrial appendage. They will actually prolapse into the left atrium and then cause the cardioembolic stroke. But when you occlude these type of things, left atrial appendage, you don't tend to have these type of clots forming there, and then they can't cause the embolism and the stroke. So now comes what type of patient should be taken for a left atrial appendage closure. So more importantly, the patients who have got either a CHA2DS2-VASc score of more than 2, and then you are not able to give them anticoagulation. So the problem comes with if the patient has anticoagulation induced bleed, or else is Hasbled score, which is considered to be a score which shows that patient is having increased risk of bleeding. Supposedly patient is having a chronic kidney disease or a chronic liver disease, has low platelet counts, and these patients are at increased risk of bleeding. You will not be able to give them anticoagulation in the form of even a DOACs or the previous one, which is the warfarin and the acetron. In these cases, what we try to do is we try to occlude the left atrial appendage, which is almost practically possible in 99% of the cases. Whatever morphology of the left atrial appendage is, we exclude the left atrial appendage, and then these patients will require only single antiplatelet drug only for 3 to 6 months, and you can even stop the antiplatelets after 3 to 6 months. So that's the best part of occluding or excluding the left atrial appendage, is you take care of the causes of almost 92% of these strokes. So atrial fibrillation is a big problem. We know that our population is going to age. We have a huge number of population in India, 140 crore population. And these patients are going to come up because the aging population has got a higher risk of atrial fibrillation. And as the comorbidities of these patients are going to rise, we may have problems of multiple patients coming up to us on DOACs or warfarin, having chances of bleeding where you can't give any further anticoagulation, and you need to treat them with some sort of thing that you can't give him anticoagulation, but you still need to decrease their risk of stroke. And in these cases, left atrial appendage closure is one of the very good therapies. What you can do is you just plug in the left atrial appendage, exclude it from the system, and just don't give them anticoagulation. Just give them antiplatelet for 3 to 6 months, and that is done. I'm sorry I could not present my case in detail because of the crashing system of this place, but I'm able to talk through my phone. I'm sorry for this. And over to Sucharita to continue with the process.
Thank you, sir. A lot of insights from your talk, and I wish you could have seen the videos, but I think it was a great learning experience. Over to the organizers, Sudhir sir, Lakshmi sir.
Good evening. It's a outset my hearty thanks to the PGI team headed by Dheeraj and Sucharita, and excellent disposition of the entire complications of atrial fibrillation, conventional anticoagulations, NOACs, NOACs-related bleed, and the surgical, the left atrial appendage closure, and an excellent overview by the cardiologist, Dr. Parag. And overall, it is so useful for the entire students across the country. I'm very, very thankful to you for choosing such a wonderful case. This is a very, very practical case. And I just wanted to know whether in NOACs bleeding, have you used the antibodies? Is it available across in your place, or is it any one of the monoclonal antibodies which we use? It is adroxizumab or anyone which is available across in the country, or it is not available?
So Dheeraj sir is there with us. Sir, would you be taking it on?
Yeah. Hi everyone.
Hi.
Hello Lakshmi and
Yeah,
hi
hi, Dev.
Sucharita.
Excellent
Hi,
case. Thank
Parag.
you. Thank you so much.
Welcome,
Sorry I
Dr.
couldn't
Dheeraj.
join. Hello sir. How are you, sir? How are you, sir?
Fine, thank you.
How are you, sir?
Welcome, welcome. Yeah.
Thank you. Actually, I am driving, so I won't switch my camera on. It'll distract me. So, but it was an excellent account of the whole, NOAC-induced bleed as well as AF management. It was covered excellently by Sucharita, updating us on the guidelines for this as well as the indications where we need closure. And Parag has done a great job with the patient. So about the antibodies, so we do have a Darucizumab available very easily, but that's for dabigatran alone because that's a FAB against the dabigatran molecule. As far as Andexanet is concerned, it would be available, but not being very frequently used. However, we do have the PCC available, which is also an alternative for anti-10A induced bleeding. This patient, however, if we see, there was an element, of course, of a NOAC, but it was a putaminal hemorrhage, which is also a small vessel disease-induced hemorrhage. So there was a contribution by both the elements. In fact, another relevant aspect in this patient, apart from, of course, a management of the AF, but that aspect would take another discussion, is to restart anticoagulation in patients who have an ICH. There are a couple of trials which are still ongoing to answer that question, and that is still unanswered. What is the long-term outcome of such patients where you actually need, in fact, in the presence of an ICH. Hello. So in presence of this ICH, I think it was an excellent idea to close the patient with a PFO closure because it becomes kind of risky to put patients back on anticoagulants. And we still need to, of course, look into the results of these studies. Are we able to completely go off the anticoagulation in such patients, or can we go with antiplatelets? That would be really interesting to see, because patient who's had a bleed does have a high risk of a recurrence of the hemorrhage again. Till that time, we are not really sure, but I think this patient is still back on anticoagulation. Am I correct, Charita? Or
No, he's on antiplatelet.
Now he's on antiplatelet.
He's on antiplatelet.
Right. So that's a good option since he's already been closed.
Dr. Dheeraj, a quick question to you. You still follow the Diener's law?
Yeah, the Diener's law is good, but now I think we are very well updated with the ELAN trials. So ELAN trials have really well informed us. I think we should change practice now. Diener's law is good with 13612. For general guideline, we should educate at least the residents and physicians to use that. But ELAN trial has informed us well that even for larger strokes, if we start early anticoagulation, they do still better than starting late. So there is no difference actually. Okay. So that the sub-study which was just published.
That's a very good information. Thank you.
Yeah. So that's I think that covers most of the things.
Thank you. Thank you so much, Dheeraj.
Okay.
A question for Dr. Parag, and maybe Sucharita or Dheeraj can answer. How frequently you use cardiac MRI for decision of atrial appendage closure or some other pathologies in the heart?
Sir, this is Parag over here. So, sir, truly saying, we don't use cardiac MRI for the decision of making closing the left atrial appendage. Truly saying, so the decision to close the left atrial appendage is based upon the morphology of the left atrial appendage as well as his risk of bleeding and stroke. If the risk of stroke is also high, risk of bleeding is also high, then you need to close the appendage. Morphology of the appendage is best seen on a CT scan because that gives you a very detailed morphology. And based upon the size and morphology of the left atrial appendage, you determine the size of the device which can be used to close the defect. So we usually do not use cardiac MRI for the left atrial appendage closure.
Right.
But one more important thing, cardiac MRI can be used for diagnosing left atrial cardiomyopathy.
Yeah, that is true. I think that should be useful. The second question is, what are the shortcomings of this left atrial closer devices, including umbrella and whatever devices are available.
So there are
So,
two varieties of devices which are available in India. One is made by Boston Scientific, which is the Watchman, and second one is the Amulet by the Abbott company. The shortcomings of these devices is if you don't give them antiplatelets for initial 3 to 6 months, there is still a possibility because it's a foreign material in the left atrial appendage. There is still a possibility that you may form some clot on the top of the disc, which has been put on that, and there is still a possibility of you having a stroke in the initial 3 to 6 months. That 3 to 6 months is very important till the time it gets endothelized. Once it gets endothelized, then you have a natural covering on that of your own body, and the chances of stroke goes down significantly.
what is the exact response rate of atrial closer, appendage closer device? How much percentage is covered by that? You mean, is it 80% to the tune of 90% or what?
It's 99%, sir.
Then why we don't advocate it very early on when we have atrial? Why we want to go through all this knocks, dogs, and then bleedings and this and that?
So
Is it
because you're
because the
taking
cost?
care of 92%, you're not still taking care of that 100%, because if you have atrial cardiomyopathy, the stroke can happen because of a clot forming on the left atrium itself. We are trying to exclude the atrial appendage, which constitutes 92% of the strokes. So 8% of the strokes will still never be controlled if you take care of the left atrial appendage. And the studies have always shown non-inferiority. None of the studies have shown superiority. And that is the reason why evidence doesn't give you like a class 1 indication. It always gives you a class 2A indication, sir, in this case.
That's the specific reason why I raised the question, because at least it averts the bleeding induced by dogs, right? So isn't that advantage, if not inferiority or
Yeah,
superiority?
definitely, sir. Definitely. I completely agree with you. And in the Western world, it has been rampantly used. We still don't have that much amount of financial access, and it's not covered under various government schemes. So it is not easy for patient to get this procedure done. In government, it costs 2.5 to 3 lakh, and in private, may be causing double or triple of that. I am really not aware of that. So finances is also a big concern.
Yeah.
It is
Lakshmi, what
also
is your
skill
take on
dependent. It's also skill
Yeah,
dependent, sir.
I would totally echo Parag's thoughts. And since the trials, as he has mentioned, have only showed non-inferiority, we need to do it on a case-to-case basis. And, you know, for a general population, even if we were to offer this, we would not have, one is the financial access, as well as maybe the turnover for such a big population. AF is rampant in our population. We would be happy to at least, at a physician level, at a peripheral level, even if all these patients are started at least on a NOAC. Like this patient was not on a NOAC initially, was on warfarin. I think that's the biggest, one of the learnings which should go from this case is that NOAC, our heightened...
Right, Dr. Dheeraj, as we do more and more ELR, as we build up our experience.
Yes, sir. Exactly. So ELRs, of course, for paroxysmal AF or occult AF, that is absolutely needed. But clear-cut AF, I think NOACs is the call of the day. In fact, it's been decades now.
ELRs, we are picking up many more.
Absolutely. We do that quite routinely here, and we pick up quite a few more patients. But since NOACs have a superiority over the vitamin K AF or the non-valvular AF, I think we should not shy away from using NOACs. They're easier to use, safer to use, no interactions with most of them.
Agreed. Agreed.
Yes.
Absolutely. We follow at our center the same criteria, but just for the sake of discussion and for the knowledge of participants, I raised some questions. So I am happy that you answered well, and thank you very much for the wonderful case and very nice discussion. Specifically, Dr. Sucharita and Dr. Parag did a wonderful job. So nice of you. Thank you very much.
Thank you, sir. Thank you for the opportunity.
Dr. Lakshmi, closing remarks from your side?
Sir, I already done. Thanks to the entire team. And now I request the Mr. Arun Chadha to take over.
Thank you. Thank you, sir. And today we are incredibly grateful to all of you for joining us in the Secret of Neurology. And we are very thankful as since we are completing our 54th session of this insightful web series. On behalf of Intas Pharmaceutical, I, Arun Chadha, Vice President of Intas Pharmaceutical, extend the heartfelt gratitude to all of our esteemed delegates for joining us on this momentous journey over the past 54 months. I especially thankful to our esteemed course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology. This program is undoubtedly a valuable resource to all the DM and DNB students. And we are incredibly grateful to the young neurologist, Dr. Shipra, for sharing their insightful case presentation. And we are thankful to Parag sir for localizing this case and giving the better aspects as far as the cardiology point of view. And we are thankful to Dr. Sucharita Ray ma'am for giving insight of this case and providing the crucial learning points and summarizing the proceeding of unique presentation. And our gratitude goes to Professor Dr. Dheeraj Khurana sir from PGI Chandigarh, who has given the insight of this case and given the valuable points how to go in this case also. Once again, a heartfelt thankful to all of you for your gracious presence, and it is being a true pleasure being with all of you on this 54th edition of Secret of Neurology. And once again, we'll meet again for the next Secret of Neurology on 28th of February 2025. Until then, stay safe and take care. Thank you. Thank you very much, sir. Thank you.
Thank you, everyone.
Thank you, ma'am.
Thank you.
Thank you.
Thank you, Dr. Dheeraj.
Okay, thank you.
sir.
Thank you, sir.
Thank you. Thank you very much.
Thank
Good
you,
night.
Lakshmi sir.
Thank you, sir.
Thank you, Chudai.
Thank you very much.